Hello, welcome to the conference. I'm Dr. Michael Fossel, and I'm going to talk about something that sort of overarches everything we're talking about with regard to dementia, and that is a unified model to understand the dementias and the prospects for an effective intervention. So rather than simply talking about dementias in general and dementia care in general, the question is, can we cure it? And the answer, I think, is we probably can, but to do so really requires us to understand dementia. And we don't. We have a broad feeling for what dementias are, Alzheimer's, for example, but we tend to lose sight of the actual interactions, the mechanisms that occur, the cascades of disease that go from, for example, genetic risk all the way down to beta amyloid, as an example. And the result of that is that since we don't understand it, we can't intervene. And I want to focus on the difference between knowledge and understanding. We have an enormous amount of knowledge about dementias. Personal knowledge, clinical knowledge, scientific knowledge, physiologic knowledge, genetic knowledge, but we often lack an understanding of the process of the dementias themselves. And so let me give you an example. This is a quote from Einstein. Any fool can know, the point is to understand. And an example would be going back 500 years ago when the Vatican astronomers had, again, a great deal of knowledge about planetary positions, but they had no understanding of orbital mechanics until along came Galileo and others, Kepler, for example, who had a very different understanding, a much more impressive fundamental understanding of the process going on, rather than simply the data points. So it's not a matter of knowledge; it's a matter of understanding. And here are some examples. We have a great deal of knowledge about biomarkers, for example, beta amyloid and various prospects, phosphorylated tau and neurofilament light chains, and so on. But what we lack is an understanding of exactly what causes the presentation to occur when it does, the course of it, why does it go faster in some and slower in others? Why do some patients have more, for example, of motor problems or cognitive problems, executive function problems? Why do these vary between the Alzheimer's, Parkinson's, and other age-related dementias? What is really going on behind all these? So I'd like to present you with something that I talk about as a unified systems model. And to give you a perspective on what I mean by this, let me take you back for myself about 45 years ago in this campus where I first got my degrees and was teaching neurobiology at Stanford. And I got intrigued by what really causes age-related diseases, particularly dementias, because my PhD was in neurobiology. And I gave then, 25 years ago this year, the first talk ever here at the National Institutes of Health on the prospects for intervening in age-related diseases. And the point I made emphatically was, if we're going to intervene in age-related diseases like the dementias, we need to understand the aging process at a most fundamental level. Well, we often don't. And the result is this sort of thing. Researchers say everything works in mice, nothing works in humans. Investors often say Alzheimer's is the graveyard of companies, particularly biotech. Well, this came to a head for me about 2 or 3 years ago when the Alzheimer's Association asked me to give a talk, actually organize a conference in Washington with a few others, on why everything works in mice but nothing works in humans. And in fact, not everything works in mice, and it also doesn't work in any number of other animals that I've worked with, including human beings, over the last few decades. And I think that the overall problem, as I've sort of implied, is that we're digging in the wrong place. We tended to go after signs and symptoms of the dementias, such as beta amyloid, tau tangles, genetic risk factors, inflammation, microglial activation, lymphatic changes, without actually understanding what's going on. The result is we are digging in the wrong place, and therefore digging deeper doesn't help. Doesn't matter how big your Biogen ESI budget of $1 billion or the NIH budget or the NHS budget in the UK. It doesn't matter how big those budgets are. If you're putting all that money in the wrong place, you're not going to get good results. And in fact, we have not. These are figures that I took from just a few days ago from the clinicaltrials.gov website, where we register a number of global trials. And if you look just at interventional trials over the past many years, there have been, for example, with regard to Alzheimer's disease, about 2,100 interventional trials, which by global consensus, and anakinumab and Biogen notwithstanding, have failed to affect any substantive change in the clinical outcome for patients with Alzheimer's. And the same is true of Parkinson's and dementia generically. And in fact, if you look at where we are with regard to things like monoclonal antibodies, you see the same thing. We saw anakinumab released earlier this year by the FDA in June. A number of other drugs have been considered to be ineffective, and others are still in the pipeline and have expedited status. But again, if you look at the data, what you see is this sort of thing. This is the data plotted out for anakinumab, What you see is that for various ascending levels of dose, including dose 3, which takes a sort of a skewy line, you just get this temporal step off of, for example, 6 months, where the patient still has severe cognitive decline, but you postponed it for a little bit, but the disease course then parallels the placebo course downhill. That is, ultimately, you have no effect on the disease course. And what we'd like to do is see something much more dramatic, which is we'd like to stabilize the disease course, prevent the patient from going downhill, and if possible, actually improve cognitive status. So I don't think that we can say that we have affected a significant result in trying to treat age-related dementias, but we could. And as I say, the major problem is that while we have a lot of knowledge about biomarkers and risk factors, we have very little understanding of the process itself. So with that in mind, let me tell you about a paper that I wrote that came out just last year that summarized where we are in this and offered a different model, as I say here, a unified model of age-related dementias and neurodegeneration. And it grew out of that conference in Washington. And it tries to encompass all of what we know about biomarkers, risk factors, age-related changes, closed head injuries, exposure to toxins, microbial disease, and the outcomes, beta amyloid, tau tangles, in the case of Parkinson's, alpha-synuclein changes in the substantia nigra, and explain why these things happen. So what we're looking at really is a unified model and a systems model. And let me explain what I mean by that. When I talk about a unified model, what I'm saying is we need to be able to explain all of the upstream risk factors. That is, we know, for example, that if you have two ApoE4 alleles, you have an increased risk for Alzheimer's. But why? We know that if you have head injuries, you have an increased risk. But why? We know exposure, for example, to paraquat increases your risk for Parkinson's. But why? And the same is true of any number of other upstream risk factors, which we know are risk factors, but we don't know why. Likewise, the downstream outcomes, the biomarkers, for example, beta amyloid, a lower ATP ratio, inflammatory changes, all of these things we see in dementias and other age-related diseases. But why? Why do we see beta amyloid deposition, for example, or alpha-synuclein aggregates in the substantia nigra? Why do we see these things? What underlying process is below these? And if we look at it clinically, we'd see the same question about a sort of an overall process here. We know that there are very real clinical syndromes, all too real, like Alzheimer's and Parkinson's, and yet there's overlap. So some of our Alzheimer's patients have motor deficits, many of our Parkinson's patients have cognitive deficits, and many of these patients at autopsy are found to have vascular underlying factors. So whether we're looking at frontotemporal or any number of other sort of alphabet soup of the dementias, the age-related human dementias, we see that many of these are mixed, many of them are atypical. And the question that's come up in the past decade or so is there an underlying process that explains all of these different dementias? And we start at different genetic and epigenetic and behavioral starting points, and we end at different clinical outcomes, but there's a unified process that essentially explains all of these. And that is there an age-related neurodegenerative process that underlies all of these? And I think there is. Now, when I talk about a systems model, that's a little more subtle, perhaps. And let me explain what I mean by a systems model as well as a unified model. This is an Airbus 380 cockpit, and that's the Rolls-Royce jet engine that powers it, and the turbofan that powers the Rolls-Royce jet engine, and a single turbofan blade. And when that fan blade fails, a biomarker, if you will, a sign and symptom, we don't ask simply what's wrong with the fan blade, what's wrong with beta amyloid. We ask what's wrong with beta amyloid in the context of, in this case, the Trent 900 turbofan and the Rolls-Royce Pro 15 jet engine and the Airbus 380 at 35,000 feet going hundreds of miles an hour at a high RPM and high temperature. In short, we're trying to understand the process, the overall unified systems process, not just the components, not just the biomarkers, but how do they fit together in, for example, human disease? For example, these are COVID biomarkers, typical signs and symptoms of COVID. But no matter how carefully you measure these biomarkers, they don't explain the system. That is, they don't explain the disease process, the infection process between the COVID-19 and the human immune system and the organ systems that fail. So we need to dig deeper than just understanding biomarkers. And the same is true when we look at age-related diseases. For example, these are age-related biomarkers, but by themselves, they're not aging. They're simply biomarkers of aging. And the same is true at the microscopic level. No matter what we're looking at, we can measure them very carefully, whether it's acetylation changes or telomere shortening. By themselves, those are not aging. They are biomarkers of aging, but they're not the overall process. They're not the dynamic process, the system that's going on at a deeper level. And the same is true when we look at the dementias. These are typical biomarkers for human dementias. For example, lymphatic changes or failure of the blood-brain barrier, alpha-synuclein aggregates, and so on. And we could list dozens, hundreds perhaps of these, but that doesn't tell us how dementias work. It tells us some of the outcomes of various dementias, but not the process. So the same is true when we look at the dementias at the genetic level. I know of more than 200 genes that have been implicated in increasing generally, or in some cases decreasing, your risk of, for example, Alzheimer's, ApoE4 being a classic one. But that doesn't tell us why it works. What is there about ApoE4 alleles or ApoE2 alleles as protective risk factor that explains what happens clinically? So we need to dig deeper. Now, this is a quote from a friend of mine, Len Hayflick. Dr. Hayflick was the first person to describe cell aging 60 years ago this year. And as he says, almost all of us would agree that aging is the single most predictive risk factor for age-related dementias, for example, Alzheimer's. If I want to know whether a random patient has Alzheimer's, the first question I might ask is, how old are they? But we then tend to ignore age and focus on physiology, vascular problems, focal findings on the targeted PET scans, without asking ourselves what's really going on and what does aging have to do with it. So I think that if we're going to do anything about age-related dementias, we have to start by going down and understanding the fundamental process of aging itself. So to do that, let me introduce you to some friends of mine. We start with human beings. They these days typically have a lifespan of about 3/4 of a century. And if I look at gorillas, they have a lifespan typically just short of a half century. That is Coco, the gorilla who spoke sign language. I was her babysitter for a year at Stanford, which was a remarkable experience. She is now dead. If I look at typical domestic animals, you're looking at, say, 15 to 20 years, depending on the species, the breed, and individual variation. If I'm looking at typical laboratory rodents, you're looking anywhere about 2 to 3 years for a lifespan for some of these rodents. But the question is why? And most of us would sort of wave our hands and say it's genetic, which is fair as far as it goes. For example, that mouse and you and I share about 75% of protein-expressing genes, and the presumption is that the reason that we age about 40 times faster than that mouse is because of the other 25% of genes and regulatory components. But that doesn't explain it. You've just said where you're not looking. You're not explaining what the process is. The same is true even within human beings. If we look at age-related changes in different human beings, in this case, Hutchinson-Gilford-Progeria children. This was, I used to gather them together from all over the world about 2 decades ago, and this time we'd taken them to a tour of the White House. We're at the North Portico here. And these children die of an average age of 12.7 years, overwhelmingly of age-related diseases, typically strokes and heart attacks, but they also have osteoporosis, osteoarthritis, thin skin, loss of hair, as you see with most of these children. But the question is why? Now, we know, or think we know, the gene involved, which is the lamin A gene. But that is not an explanation. We have told ourselves where to look, but we have not yet explained why that occurs or how we can intervene effectively. So to say something is genetic is not an explanation. It's simply localizing where to look more carefully. Nor is aging ubiquitous. For example, every cell in your body which demonstrates age-related changes now over a few decades was inherited as a fertilized ovum from your mother. It was several decades old at that point. She got it from her mother, which was several decades older at that point. And that line of cells can be traced back in an uninterrupted biological line for about 4.5 billion years. And it demonstrated no retrospective aging until the last few decades. So why does aging not occur retrospectively and yet does occur in you and I in most of our somatic cells? Some people would say, well, it's because of mitochondrial failure, but you run into exactly the same problem, which is every mitochondria in your body, which demonstrates age-related changes now in most of you. It was inherited from your mother, who got it from her mother, and that line goes back, depending on who's doing the estimate, about 1.7 billion years. And during that time, there was no evidence of aging in that mitochondrial line. That is, the mitochondria you and I inherited at fertilization were flawless, essentially. And yet, over the past few decades, you find subtle changes in dysfunction of those mitochondria that are consistent with aging. So why does aging not occur in some cell lines and some mitochondria, and it does occur in other cell lines and other mitochondria? In short, we haven't explained it. Well, part of the problem is most of us tend to assume that aging is simply a matter of entropy, that is wear and tear, without focusing on maintenance. And what you find is that if you look at the germ cell line, or in this case, if you look at, for example, mitochondria in the germ cell line, you find that maintenance is essentially flawless. That is, while entropy and wear and tear are going on throughout those billions of years, so is maintenance. Now, the same is not true if I look at, for example, the cells in that 80-year-old hand on the left there of the man in the wheelchair. If I look at his fibroblasts, keratinocytes, endothelial cells, microglia, what you find is that the cells have subtle defects in maintenance compared to, for example, the germ cell line. So entropy is occurring in both cases, but maintenance shows failure in most somatic cells. In short, it's sort of like the quote from the Red Queen in Through the Looking Glass by Lewis Carroll, in which she said we must run as fast as we can just to stay in one place. And that's what the germ cell line and retrospectively mitochondria have been doing for billions of years. They run as fast as they can in terms of maintenance to keep up with entropic change. But that is not true when I look at your somatic cells. If I look at any molecular pool, for example, beta amyloid in my patients with dementias, what you find is that the molecular turnover of, for example, beta amyloid is very fast in young people. But as we get older, the turnover rate of beta amyloid, as an example, slows down. And the result is you gradually get an accrual of damage, that is dysfunctional molecules, such as beta amyloid, which we'll look at in a minute. You can actually look at this mathematically. This is taken from my Oxford University Press textbook on cells aging and human disease. But what you see is that in young cells, where there's a rapid turnover, there's very low rate of damage at equilibrium, whereas in older cells, where there's a slower rate of turnover, or recycling, if you will, the rate of damage, the accrual of damage at equilibrium is much higher. And the outcome is not only dysfunctional molecules, dysfunctional cells, dysfunctional tissues, but clinical age-related disease. So let's look at an example with regard to central nervous system aging, in this case, the dementias. In Alzheimer's patients, we would look at, for example, beta amyloid. And again, in young cells, what you see is the turnover rate of beta amyloid is very rapid. That is, microglia, for example, produce it, secrete it, bind it, re-internalize it, degrade it, produce it. There's an entire recycling process going on, and it's very rapid in young microglia. But as we get older, that begins to slow down. And as microaggregates form, as beta amyloid begins to stick together and you get these microaggregates, you begin to get the onset of early changes consistent with Alzheimer's. Now you might ask, where do genes play a role in this? For example, if I have two ApoE2 alleles, I make unsticky molecules, beta amyloid molecules, and the result is I don't get much in the way of beta amyloid aggregates. So I've got low risk alleles, and the result is I have fairly resilient cell function in terms of neuron. But if I have two ApoE4 alleles, I tend to make stickier molecules. These are high-risk alleles, and the outcome is that cell resilience, it goes down because you begin to get these beta amyloid microaggregates. Because again, it's the same rate of turnover as someone with low-risk alleles, but you're making stickier molecules, so the outcome is a greater risk of clinical disease, both in terms of onset and progression. Well, in any case, as we get older, we tend to have higher and higher risk for not only microaggregates, but in fact, frank beta amyloid plaques, and the outcome of that, of course, is cell dysfunction, synaptic loss, necrosis, and clinically, what we see as dementia in all of our practices, our friends and ourselves. This is not only true of beta amyloid, it's true of tau proteins, the mitochondrial dysfunction, which we'll look at in a minute, inflammatory changes, and so on. For example, most of your mitochondria derive their molecules, in this case, their aerobic enzymes, about 99% of them, are produced in the nucleus. And as we find that there are subtle changes in the turnover rate of these molecules, the result is more dysfunctional aerobic enzymes in our mitochondria. So the ratio of ATP production to free radical production, the reactive oxygen species, goes down. You don't make as much energy, you do make more free radicals. Also, the membranes, the lipid membranes that surround the mitochondria, are also turned over regularly, and that rate of turnover goes down. So the membranes begin to fail, become more porous, and they leak free radicals. Your scavenging molecules in the cytoplasm, for example, superoxide dismutase or catalase, are also being turned over more slowly. So scavenging is less effective. And finally, when there is damage to molecules, that's being turned over more slowly. So for four independent reasons, you find that we get changes in mitochondrial function as we get older, all as a result of cell senescence changes within the nucleus. In this case, because of subtle changes in gene expression, which are modulated by telomere shortening. The same is true of DNA damage within the nucleus. There are four major families of DNA repair enzymes that detect and then excise, replace, and ligate in the DNA basis for mutation and damage. But all four of these are slowed down as we get older, and they're all four of them modulated by telomere shortening and cell senescence back in the nucleus. So when we're looking at age-related diseases, downstream factors and upstream factors, the central factor is cell aging. What you see is that as cells divide over our lifespan, your telomeres shorten. The result of that is almost directly a very subtle change in the pattern of gene expression, that is epigenetic pattern shift. And the result of that is that molecular turnover, for example, beta amyloid, slows down. And the result of that is you begin to get these aggregates in the case of beta amyloid and Alzheimer's. Cells fail and die, and we see clinically Alzheimer's and other dementia diseases, as well as other age-related diseases. So the upstream factors all play a role in this central process of cell aging, and the outcome is all of these downstream biomarkers. Treating downstream biomarkers is not effective, as in the case of anakinumab. Treating the upstream risk factors has some impact, but not a great deal. For example, we can try to control hypertension or elevated glucose and hyperglycemia and make the patient euglycemic, lowering your risk for vascular disease and vascular dementias, but it doesn't prevent vascular dementias. It simply lowers the risk and slows the course of the disease. So the question is, can we do something much more effective? The answer is yes. And that optimal point of intervention almost certainly is to intervene directly in cell aging. Now, the real question is, can we do this? And the answer is, it's already been done. This is an article from Science magazine, and this is an article by Andrea Bodnar and her group out at Geron Corporation now 23 years ago. And what she showed is that we can actually reset aging in human cells in the laboratory, reset the pattern of gene expression, and they physiologically, histologically, morphologically all look like normal young, in this case, human fibroblasts. The same thing is true if we look a little more carefully at human tissues, not just human cells, but human tissues. This is Walter Funk's article from 21 years ago. And what he did was show that you can actually take human skin cells, old human skin cells, and regrow young human skin tissue simply by resetting telomere lengths and resetting cell aging. So we know we can reset them. The question is, can we do that not only in skin tissues, but in this case in osteocytes, and in this case in vascular and epithelial cells, all of which has been done about 20 years ago. But can we do this in animals? And in this case in humans as well. Well, the first article that looked at that was now about 10 years ago, a paper out of Harvard with Rhonda Pinno's group, but it was done using a technique that doesn't help us clinically because he altered the germ cell line. But this is a better paper out of Maria Blasco's group, a friend of mine in Madrid, who was the director of CNIO, the De Jesus paper. And what she did was used a gene therapy technique that's in current use now for a number of gene therapy applications, for example, the Avexis, Novartis, Zolgensma work. And what she found is that you can actually reset the behavior of old mice to that of young mice, as well as increase the lifespan, improve the bone mineral density, subcutaneous fat, and immune function, as well as a number of other physiologic measures. So we know that it's doable to a degree. The question is, can we do this in human beings? Well, using this model, we probably can. The advantage of this unified systems model I'm talking about is that it provides an accurate explanation for dementia, and it provides us with an optimal point of intervention. Moreover, the model explains upstream risk factors, why it is that, for example, closed head injuries affect your rate of Alzheimer's or Parkinson's. Downstream biomarkers, why it is, for example, that beta amyloid plaque occurs. And the clinical heterogeneity, that is, why do I get Alzheimer's, you get Parkinson's? Why do I get Alzheimer's early, you get it late? Why do I have executive function problems and you have more motor problems? Why do these occur? Why does this heterogeneity occur? It gives an explanation for it. Moreover, it's consistent with all the known research and clinical data available at this time. Furthermore, it's been predictively valid. This model has actually, ahead of time, predicted the results of the Eli Lilly solanezumab trials, the Biogen Eisai anakinumab trials, and other trials. It predicts the exact same results that we see when we take this to FDA human trials. The interventional target that we're looking at, in this case cell aging, is not only novel, but it's now technically feasible, and it's been shown to work in vitro, in human cells, ex vivo, in human cells and tissues, and in vivo in animals. So it's certainly worth taking to human trials. Our priorities in doing this will be, one, credibility, because we think we're about to do something that has never been done before historically, and therefore we need to make sure we do it right. We need to make sure it works, that it's safe, and that it's low cost, and that it's done as rapidly as possible. Moreover, this entire approach is a platform approach. Not only is it likely to be effective for CNS diseases, such as all of the age-related dementias, and some age-related diseases that you might not think of as dementias, for example, amyotrophic lateral sclerosis, but for other diseases, for example, cardiovascular disease, age-related cardiovascular disease, in this case vascular endothelial cells, as well as chondrocytes in the joints, osteoarthritis, osteocytes for osteoporosis, renal podocytes for chronic renal failure, leukocytes in the case of immunosenescent skin cells, and so forth. So the potential is enormous. So the real questions are these. One is, can we effectively intervene in the aging process at the cellular and tissue levels, and specifically at the genetic and epigenetic levels? And the answer is unequivocally yes. Not only can we, but it's been proven. It's quite clear that we can intervene in the aging process at those levels. The real question then is, can we intervene effectively in age-related clinical disease in human trials? And there the answer is, we'll have to see. We're going to take this question to human trials as soon as we can. Our investors behind us on this, and see what we can find out. But our intent is to not only show that we can understand human dementias and human dementia care, but can actually intervene effectively and both cure and prevent age-related human dementias. I'd like to thank you all for listening. I hope you found it an interesting discussion. If you're interested, please feel free to get in touch with me, and I hope you enjoy the rest of the conference. Thank you all very much for joining me today.